and faculties and delegates. So continuing with the academic festa revolving around children and kidney, the second day's first session will be on will be on complement mediated nephropathies. First session is rheumatology nephrology crosstalk by Dr. Sujata Sani. For this session, I invite our chairpersons, Dr. Ashok Kumar Vaidya. He is Vice Chairman, Paras HEC Hospital, Ranchi. Earlier had also been at Medga Super Speciality Hospital, Ranchi and Nephrology Kidney Care Clinic, Ranchi. I invite Dr. Prabhakar Yadav, who is Senior Consultant Nephrologist at Tata Memorial Hospital, Jamshedpur. Dr. Amit Kumar, he is Senior Consultant Nephrologist at Medanta, Ranchi. I invite Dr. Megha Sehgal. She is Assistant Professor at AIIMS, Patna. And Dr. Arun Sah, Consultant Nephrologist. I hand over to proceedings to our chairpersons to introduce our esteemed speaker.
First session of second day on rheumatology and nephrology cross talk. And for this session, I will be inviting Dr. Sujata Shani. She is senior consultant pediatric nephrologist, rheumatologist from Sir Gangaram Hospital, New Delhi. She has special area of interest in childhood lupus, Kawasaki disease, and she is first trained pediatric rheumatologist in India, and she has set up first dedicated pediatric nephrology service in private arena in India. She runs fellowship programs. She is editor of 2 books in pediatric rheumatology and more than 35 publications. So over to Dr. Sujata, please.
Thank you so much and good morning. Thank you to Dr. Hemant for inviting me over. It's a pleasure to be here, and thank you to the audience who has come on a Sunday morning at 9 a.m. to listen to this. So the topic given to me today is nephrology, rheumatology, crosstalk. And I'll try and do justice to this topic today in the next 20-25 minutes. So these are 2 specialties that work very closely together, not only to help give a rapid diagnosis to the patient who presents to us, but also to assist in the management and very often in several situations to go ahead with combined care. So from a rheumatological point of view, the kidney is a bean-shaped organ that sits in the retroperitoneum, and that's all we know about the histology of the kidney. But when you look at all the rheumatological diseases that can affect the kidney, this is Dr. Rathi's paper. He's very nicely pointed out that several rheumatological diseases can have renal involvement. And the site and the severity of the renal involvement is very often the dominant clinical feature for the disease. Now you can go to any standard textbook and look at rheumatological diseases and the kidney or nephrological presentations of rheumatological diseases. But what I'm going to do for you in the next 20 minutes or so is to show you some very interesting cases from whom we learn a lot about the rheumatology, nephrology crosstalk. And I'll try and leave you with one take-home message for every child that I'm going to present today. And please feel free to stop me and ask any questions as you would like. So this is the story of an 8-year-old girl. She was well until about 10 months ago. She had an upper respiratory infection, and 2 weeks later she began to develop palpable purpuric lesions on the lower limbs, but you can see she also had some larger non-palpable purpuric areas. Additionally, what was of concern was that this patient started developing increasing pallor. She also had severe episodic abdominal pain and interestingly developed a non-infectious redness of both the eyes, non-infectious because it was not discharging. She first had redness of the left eye and a few days later had significant redness of the right eye. With these complaints, she was admitted to her local center, diagnosed to have Henoch-Schönlein purpura, or IgA vasculitis as it today called, and the child was given intravenous pulsed methylprednisolone. However, she was hypertensive, her palpable purpura began to increase, and her blood reports worried the local team, where she had a marked anemia and she had severe proteinuria. So this child was sent along to us for an evaluation. When we saw the child, could this child have Henoch-Schönlein purpura? Yes, but there were some interesting red flags. The child had significant anemia. She had had inflammation of the eyes, which had now settled after the steroid, which is not seen in this condition, and she early on had very heavy proteinuria. She could have lupus, it is possible. Post-streptococcal glomerulonephritis, this is not the presentation with palpable purpura. And of course, another diagnosis, which is very rare in pediatrics, is of ANCA-associated vasculitis, is what we kept in mind. When we went ahead and evaluated this child, surprisingly, she turned out to have ANCA-associated vasculitis. Her PR3 antigen was significantly elevated. Her complements were normal. She had rapidly progressive glomerulonephritis, and we started treating this child. We induced remission with IV cyclophosphamide, and after giving her 6 cyclophosphamide doses, we are maintaining this child on rituximab. Currently, it is about 10 months since we saw her. Her PR3 is undetectable. She has no proteinuria. She has a normal EGFR, and she is doing very well. And this is a renal biopsy that was done on this patient. And I would like to acknowledge our pediatric nephrologist in Gangaram Hospital, Dr. Kanna, who has been very kind to share some of these slides with us. So from a pediatric standpoint, we are always concerned then about Henoch-Schönlein purpura. Up until now, we were not certain as to which patient requires a renal biopsy and how do we classify the severity of nephritis of these children. It has now been very simplified, and there are excellent European guidelines, and these guidelines are called the SHARE guidelines, and SHARE is an acronym which stands for Single Hub Access for Rheumatological Patients in Europe. So this is a wonderful guideline which is very user friendly and explains to us how we define mild, moderate and severe nephritis in the context of IgA vasculitis, and it also gives us nice guideline as to when we should biopsy this patient. So clearly this patient had a significant nephritis involvement and certainly required a kidney biopsy. And as pediatricians, when we follow the children with Henoch-Schönlein purpura, there are 3 things that we must look for on a very regular basis. Must monitor the blood pressure of the child, look at the first urine sample of the patient, and monitor the EGFR. Early on, in the first couple of months, one could do this fortnightly, then move it to monthly. But remember that there can be children who have late onset significant nephritis, and therefore we should be doing a urine dipstick and blood pressure monitoring for at least 6 months after disease onset. So this child then teaches us that though her clinical presentation looked very much like a Henoch-Schönlein purpura, there were certain red flags that would suggest to us that we need a careful and rapid evaluation for these children. So in rheumatological diseases, when there is inflammation, especially in the renal bed, time can be of significant essence for these children because you want to dramatically reduce the inflammation without letting damage occur. So these children do require careful and quick evaluation, right? So let's move to the next patient. This is a 16-year-old child who's a resident of Nairobi. She came to our medical attention in May of 2017. Unlike in the adult world, where we have patients with lupus presenting cross-sectionally with many of the clinical features such as fever, malarash, cytopenia, nephritis, serositis. In children, it can be a vertical presentation. That is to say, you can have different systems involved at different points in time. And this unfortunate little child had been unwell for 5 years before presentation, when she had serially had low platelets, had a pericardial effusion, had polyarthritis, and it is only when she developed symptomatic nephrotic syndrome with facial edema, hypertension, puffiness was the diagnosis of lupus reached for this patient, and she was seen by us for the first time in May of 2017. She had a renal biopsy done and she had a significant chronicity but did have some activity. Her eGFR was reduced to 58 and she had a significant proteinuria of over 2 grams. Now this child has been in our follow-up over 6 years. I follow her with pediatric nephrology, and she has done really very well. So in patients who have impaired renal function, As rheumatologists, we would always co-opt a nephrologist to help us to look after these patients so that we can give the child the best possible metabolic environment, look after the acid base, pull down the uric acid, give the correct form of vitamin D, make sure the blood pressure is normal. And 6-7 years follow-up, and this patient is stable, she's attending school, her proteinuria is down to 200 milligrams, she's normotensive, her EGFR has also come up to 78. So the longer we can delay a renal transplant, the better it is for this child. And with a combined care, we can help these children. So as rheumatologists, when do we seek help from nephrology in children with lupus then? So of course we also need an excellent renal pathologist because we always co-opt them as well to understand what is happening in the kidneys of the patient, and we would require the help of nephrology to help with the fluid electrolyte balance, to help the blood pressure of the child, and both in situations of acute kidney injury and a chronic renal impairment, we would always work with nephrology to offer the best possible outcome to these patients. So I've shown you two extremes, ANCA-associated vasculitis, and I've shown you also a child who is a late presentation of lupus. So remember, in children with lupus, 7 out of 10 children will develop nephritis, and it is the duty and the role of the team looking after the children to carefully evaluate the urine sample on a regular basis. The highest incidence of lupus nephritis is in the first 2 years. And if you want the child to develop lupus nephritis, then you should stop hydroxychloroquine. That is to say, hydroxychloroquine is the background of treatment of all children with lupus, regardless of the organ involvement. So let's move on to this other interesting child. This is a very interesting girl, a 12-year-old girl who was referred to our center, and she really presented with a monoarticular disease of just the knee joint, which had been there for 2 months. She also gave history of episodic loose stools. She was well grown and she had only one swollen knee joint. Her fecal calprotectin was high, so we elected to go ahead and get help from our gastroenterology team. And the child was diagnosed to have a non-specific ileitis. We thought this child had a non-specific inflammatory bowel disease that we could not accurately classify. So we injected this patient with steroid and put her on sulfasalazine. She did quite well and we lost her to follow-up. About 6 months later, we got the news that she had been admitted in a private hospital with complaints of significant headache, seizures, and the local team had noted that the child had marked hypertension. She was referred on to our center, and while on antihypertensive, she was found to have discrepant blood pressure in the upper and the lower limbs, even though the peripheral pulses were well felt. And this patient did not have any previous history of any other concerning features, and there was no documented history of a urinary infection. On evaluation, she had an active urine sediment, she had an elevated ESR, and she had a mild anemia with a low normal platelet count as well. Ultrasound examination of the KUB showed that the right kidney was small in size, and when she went ahead and had a DMSA scanning done, you can see that the right kidney was not visualized. However, she did not have any VUR on the micturating cystourethrogram, and a Doppler study done that she had a remarkably narrowed right renal artery. So she went ahead and had an angiographic study done, and you can see this dilated aorta which is seen suprarenally, and you can see that the right renal artery and its branches are fairly attenuated. So this patient then was diagnosed to have aortoarthritis, and we are not very clear did she have two diseases or one because a child presenting with a monoarthritis and loose stools is highly unusual in aortoarthritis. And today we know that children with aortoarthritis may have the disease in isolation, but they can also have it in the context of some other rheumatological disorders. One thing very important that we need to know as pediatricians is that children with aortoarthritis will often present to us with low-grade grumbling fever. Thank you, Doctor. Thank you. With low-grade grumbling fever, and these patients have elevated acute phase responses. And what are these children given in our country? They are put on anti-tubercular therapy. We miss the inflammatory phase of the disease, and the child then presents either with a congestive failure or an aggravated hypertension or a seizure because of malignant hypertension and so on. So it's very important for us that if we have a patient with persistent pyrexia and elevated acute phase response, we must carefully evaluate at least the peripheral pulses of this patient and not give blind anti-tubercular therapy. So children with aortoarthritis can creep upon us, and if in case we pick them up late and they have the fibrotic stage, there's very little one can do to really help out these children. So let's pick up another interesting patient. This is a child who is 5 years of age, and she presented to us in the peak of COVID when we saw this child online. She had persistent pyrexia for 4 weeks. She had episodic abdominal pain. We had an online consult for her. Our outpatients were shut and our hospital was COVID designated. We had no beds for general or specialty pediatrics. This patient had persistent pyrexia, no loose stools, no abdominal distension. Her counts were elevated and the ESR and CRP were also elevated. The patient was reported to have a mass in the right kidney in the upper pole. A CT abdomen was done, but because of the acute situation, there was no reporting and there was no way we could read a CT online. This patient had persistent fever. She was noted by her pediatric team to have EBV IgM positive, and she was diagnosed to have infectious mononucleosis and discharged a couple of weeks after local admission. However, her pain increased and she was then admitted locally once again, and a bone marrow was done to exclude any malignancy. The bone marrow was reactive, and then 8 weeks into the illness, this child began to develop nodular tender lesions in a linear fashion. The lesions were extremely tender to touch. I'm sorry I don't have any picture for you here. We entertained an initial diagnosis of COVID because of the abdominal pain, the persistent fever, and the times that we were living in. However, there was no acute contact of this patient with the case of COVID. She was COVID RT-PCR negative. Her antibodies were also negative. So we called the child in and we reviewed the CTs, and our team felt that the child had bilateral renal infarcts, and then we went ahead and did an angiographic study, and this child turned out to have classic polyarthritis nodosa. Very interesting, she had multiple abnormalities in the branch renal vessels. We gave this child 6 doses of intravenous cyclophosphamide, which was again extremely challenging because our hospital wanted a negative RT-PCR report for both the child and the attendant at every visit. So this child went ahead and had all these things done. She was given 6 doses of cyclophosphamide, did very well. And then we wanted to put this child on maintenance, and she's perhaps the only child in my clinic where we saw that she did not have the normal TPMT enzyme. It was mutated, and so we elected to place this child on mycophenolate. She's doing very well and she's in remission. So though polyarthritis nodosa is very rare, it can creep upon us, and these children can present with significant abdominal pain and prolonged fever. What are the other areas where we often have a crosstalk between nephrology and ourselves? Well, we have this very interesting condition that is called TINU, tubular interstitial nephritis along with uveitis. We've seen only a couple of children with this condition. It is rarely reported and constitutes 2% of all causes of uveitis in pediatrics. Now, how do these children present? They present with bilateral acute anterior uveitis. These children can even have a hypopion in the anterior chamber. The most common cause of acute anterior uveitis is a child who is HLA-B27 positive, and this child was negative. And then when we looked at the urine, we found that the child had sterile pyuria, and additionally, when we asked for the beta-2 microglobulin, this was significantly elevated. And this patient had a renal biopsy, had acute interstitial nephritis and uveitis. We managed this patient with methotrexate and steroids, and this child is in clinical remission. So from a rheumatology standpoint, it is so important to look at the urine and look at the serum creatinine in children who have so-called idiopathic uveitis, because it is very easy to miss the nephritis in these patients. Additionally, the two may not occur together, and nephritis can even occur 1 year after the child develops acute uveitis. So the message for these patients is that we need to very carefully follow up. Sarcoidosis is again an unusual disorder that we see in children, but occasionally we do. It is a multi-system, non-caseating granulomatous disease that can affect any organ. And here's a child who presents to us at the age of 2 years, who's now 18 years of age. And can you see this Sargo type of nodular rash, which is very faint which is seen on the child. And the hallmark of these children actually is that they develop large tenosynovitis and swollen joints without significant pain. So these children need to be picked up early. The commonest manifestation of sarcoidosis in the kidney is the child develops granulomatous interstitial nephritis, and these children are well treated depending upon the organ involvement, either with early onset steroid, methotrexate, or even in some children using monoclonal antibodies to TNF. If these patients are left untreated, renal failure is a common complication, so we need to be aware about looking at features of not only calciuria but also looking at active urinary sediment. This is a very nice review of 36 children. This is one of the world's largest series who had renal sarcoidosis, and you can see that a majority of the children had granulomatous interstitial nephritis, and they had several other features, but heavy proteinuria has not been commonly reported in the child with renal sarcoid. We have to be careful when we use drugs in rheumatology because they can have side effects on the kidney. In early years, in the 60s and 70s, gold and penicillamine would cause less improvement in the rheumatoid arthritis and much more interstitial nephritis, but those drugs are thankfully banned to history. And today the commonest side effect we see, especially in adults, is the patient on long-term NSAIDs. We have to be careful when we use CNIs. Occasional reports of vasculitis, especially in the kidney, has been reported in patients who are on anti-TNF therapy. And of course, we need to learn how to adjust the dose of patients who have impaired renal function. Several of the rheumatological drugs needs to be carefully handled when we look at renal function impairment in the context of prescribing for these patients. Thus, ladies and gentlemen, I would like to conclude by stating that the advances in medical science today are tremendous. Specialties bring a lot to the table, but each specialist seems to wear a very narrow hat. So I hope that together we can give the child the best care, and we need to gather our teams around us so that the child gets the best available. And thank you so much for your time, your attention, and to Dr. Hemant once again for the invitation. We have a wonderful rheumatology team in our hospital. We have DNB students who come for training. We run an IAP fellowship program, and we have a vibrant team, and hopefully we are able to make a difference in the life of the children who come to our care. Thank you.
Thank you so much, ma'am, for your excellent discussion over this pediatric patients with some nephrology problem. We nephrologists come across all these like age of, we generally come with the age of 14, 15, 16, and you rightly said that if you pick this patient at even earlier age, then the morbidity can be reduced. And now the session is open for the question.
I have a question, ma'am. Ma'am, here.
Oh, sorry.
Sorry. So, ma'am, actually, I get a lot of adolescent girls with SLE who require endoxin, cyclophosphamide, because they have class 4 lupus, and generally we see that they respond very well. So I've always wondered like how aggressive we should be in oocyte preservation in such cases. Should we give lupoprolide? Should we not give in these cases? Because normally our patients, at least I counsel them, but because of the cost, we generally don't give. So in your, this thing, ma'am, do you also give, or how?
So, you know, the gonadal toxicity dose of cyclophosphamide is reported to be a total dose of about 6 to 7 grams. But we are not reaching that number at all because we are not using the NIH protocol for children with lupus nephritis. We currently use the Euro lupus nephritis trial dosing, which is very limited, and we would often complete 6 doses before we hit about 2.5 to 3 grams. So in our practice, we are not using gluperide. There's a very good paper by Brunner 4-5 years ago, Hermine Brunner from Cincinnati, where they have shown that the timing of the gluperide has to be very careful with the cyclophosphamide. Otherwise, paradoxically, you can worsen the ovarian reserve. So we need to be careful, and perhaps the uses, if you need to go very aggressive, for example, in an ANCA-associated vasculitis patient, where again we actually tend to use rituximab now, where you may want to do an ovarian preservation. So short answer is, in our practice, because we use a lower dose, we are currently not using AIM.
index was quite high. That was 7/12, and activity index was very low. So despite that, you have treated the child, and the child was doing very well. What was the renal function at presentation? Is it normal or
No, no,
impaired?
I presented, she had an EGFR of 58. So in children, even though they may have a high chronicity, if they have some activity, we will try top level immunosuppression. We were veering to go for cyclophosphamide, but because of the significant damage, we chose mycophenolate for this patient. And we've been seeing her jointly with pediatric nephrology, 7 years on, and her EGFR is now 78. Child has grown about 15 centimeters, and she's doing well, attending full-time school.
That's right. That was my second question. You have started on MMF, but actually renal function is there, so cyclophosphamide would be better choice. And when you use rituximab in your patient, I mean, when you call the patient resistant lupus with the first line of treatment.
Okay, so the current recommendations that we use come from the American College of Rheumatology and from the European guidelines called SHARE. Currently, the recommendations which were written about 4-5 years ago state that you use either IV cyclophosphamide or rituximab. There is no superiority of either of the two, but there are some situations where one would prefer cyclophosphamide. For example, the patient has a DAH, the patient has an organic brain syndrome, the patient has got severe CNS lupus. So when you want a broad, quick, rapid action, we would use IV cyclophosphamide. Or if we have adverse prognostic features in the child, such as severe hypertension, cellular crescents, and a very low complement, severe hemolytic anemia, we would use CYC. Now, your question about when to use rituximab, the two guidelines state that if either of the two agents does not work for induction, at 3 months, if the patient is worsening, you will switch the agent, or if the patient has not gone to remission at 6 months, you will switch the agent. And the role of rituximab comes after switching, as per the guidelines. But in our practice, if we induce the child, for example, with cyclophosphamide, and the child has not responded well, we would often give rituximab and then switch the agent. And I can't recommend that because that is not coming from any of the authorities.
Do you have any experience with belimumab?
It's not available in India, we have no experience.
Thank you, ma'am. One question from my side. In case of aortic arthritis, so when you decide whether to immunosuppress them or not, whether you look for disease activity in such patients before
Yes,
putting
there
them on
are,
immunosuppression?
yes, there are scores. They are called the ITAS, where you look at the aortoarthritis scoring, and we look at the MR angiograph for this patient, because the MR angiography is going to show us not only the site of disease, but it is also going to show us the thickness of the vessel wall. So when we have an initial encounter with the patient, and the patient is either febrile or has acute phase responses or has significant lesions, we will always immunosuppress. And then as we follow on these patients, we will adjust the immunosuppression depending upon what the imaging is showing and what are the clinical features on the patient. A current recommendation is to repeat angiographic study annually. So if we see new lesions or we see continued inflammation, we would continue immunosuppression.
Whether you go for biopsy in such patient, ma'am? Whether you do biopsy?
No. I'm
Usually angiography, you look for a repeat
Yeah,
angiography.
the recommendation is angiographic study. And the other thing that angiographic study is very important for is to pick up the mimic of aortoarthritis, which is IgG4. Because of those patients have got perilesional inflammation in addition to the wall.
Professor Georgie, please.
Thank you. Tell you a case report. 1996, I had a young girl with lupus, school student, presented with involvement of the kidney. So initially we used steroids, and now she is on maintenance with azothioprine, doing excellently well. Do we have to use cyclophosphamide and all these things for in the maintenance phase? Because every patient teaches you a lesson. Azothioprine, she got married, she didn't want to get pregnant, so she continues from 1996 to 2023 with low dose azothioprine with an ANA positive and 5 milligram steroids. So I'm just suggesting that do we have to follow blindly what the Americans and the Europeans say in our practice?
Thank you for that excellent question. So the current paradigm of management of the child with lupus is to treat the patient in 2 phases. where it's much like oncology today, where you first want to put out the fire by using an induction agent, and then you want to make sure that the fire doesn't come back again by using a maintenance. The current recommendation is to use either MMF or cyclophosphamide. In our practice, we have reduced the use of cyclophosphamide tremendously. And mycophenolate is as safe, if not equally safe, comparing it to azathioprine. And just to bring to your notice, sir, that amongst all the immunosuppressants we use, azathioprine unfortunately has a fairly high risk of giving the patient a new mitotic lesion. And the question also is that when we are using maintenance therapy on these patients, how long do we use it for? The current recommendation is minimum 5 years, but perhaps much longer. And I totally agree with you. You may have an occasional patient who may do very well on Azuran, but unfortunately you cannot tease out that patient from a whole group, and therefore it's difficult to recommend this for all patients.
Dr. D.K. Pahani sir wanted to make a comment, please.
Yeah, sure. I agree with you. I think we started on the kidney transplant in 90s with the azathioprine and steroid. So the problem is this: azathioprine, if you continue, the viral wards and the malignancy is higher than the what we are seeing today without azathioprine. I agree with you.
Thank you.
Dr. Rajiv, please.
Yeah, so Sujata, thank you. I think the adult world, at least in the Western, they are coming out from cyclophosphamide and going to MMF. And latest series from the European also, including the UK juvenile cohort, SLE cohort, they are also showing that even in pediatric, MMF is as good as cyclophosphamide in most of the situations. So I think one of the message maybe that should go out is that in most of the situation of SLE nephritis, I don't know about the other SLE nephritis, first drug of choice can still be MMF, unless until, as you correctly said, that we are worried about the very high severity, like a CNAs or a creatinine very high. But in most of the other situations, we have also found, and we are in the process, we have just submitted it to lupus with fingers crossed that our cohort, it was a cohort of 60 children that we saw in the last 10 years. And most of them, we used MMF, and overall there was a good outcome.
So thank you for that comment. There are a lot of issues with using MMF for every child. We are unable to give the mycophenolic acid drug levels in India. We know that there are racial and ethnic differences in the way the children tolerate mycophenolate, and a very big issue is adherence for the child who's a teenager. So we have to take everything into context before we decide which drug for which child.
So last question, Dr. Dave.
Excellent presentation, ma'am. Do you think in aortoarteritis, Takayasu PAT-based imaging has better role than MR and plain CT NG or MR?
So the issue with the PET imaging is that how do you follow up these patients? We know that the risk of a malignancy with radiation is inversely proportional to the age of the child. So though PET may help us when we are hunting in the dark, for example, for a persistent pyrexia, it does not have any role in the follow-up. Now you want to compare apples with apples, and therefore it's nice to get a MR angiography initially and then follow it up with the same modality. The difficulty with PET is that once you have the answer, how do you go ahead and follow? In our center, it's a serendipitous pickup when we are getting a PET done, for example, looking for a malignancy, and we by chance pick up an aortoarteritis. But specifically for aortoarteritis, we are not very often ordering the PET.
So thank you, ma'am. Thank you for presenting interesting cases. And there's no more questions, so I declare the session to be closed.
Thank you so
very
much. Thank you.
So, speaker and all chairpersons are invited for the memento presentation and a group photographs. Thank you. The next session is on lupus nephritis in children. So, this will be presented by Dr. Manish Rathi, and to chair the session, I invite Dr. D.K. Pahari sir. He is Senior Consultant, Department of Nephrology, Medica Super Speciality, Kolkata. Dr. D.K. Pahari, sir. I invite Dr. U.S. Rai, who is ex-HOD, Department of Nephrology, IGIMS, to co-chair the session. Uh, Dr. Sashi Kumar, Department of Nephrology, Paras HMRI, Patna. And next chairpersons are Dr. Jamshed Anwar. He is consultant nephrologist at Ruban Memorial Hospital, Patna. Uh, Over to chairpersons.
Good morning, ladies and gentlemen. I welcome you all in the second session of today. The topic is nephritis in the children. As we know that it is less common if you compare with the adult, and is very uncommon below the 10 years. But if it happens, it takes a very severe form. Mortality and morbidity is very high. Many aspects of these children in the SLE already we have listened by Dr. Sujata. The rest will be discussed by Dr. Manish Rathi. Dr. Rathi is Associate Professor of Nephrology in PGIMR, Chandigarh. May I request Dr. Rathi to start the talk, please?
Thank you, Dr. Rai. And at the outset, my thanks and gratitude to Professor Hemant, Professor Om, Dr. Amresh, and entire organizing team for inviting me here to this wonderful city of Patna. And I also like to thank Dr. Sujata. She has taken most of the questions, and she has made my job very, very easy and answered all the tough questions already. So I hope that you will not be left with any more questions at the end of my talk. So the talk is managing lupus nephritis, and are kids any different? So what we call as childhood lupus nephritis or juvenile onset lupus nephritis is when we have onset of disease before 18 years of age, and the peak incidence has been reported to around 12 years. 15 to 20% of all lupus patients are said to have onset in the pediatric age group as per the registry data. The incidence is 0.3 to 3 per 1 lakh population, and prevalence is about 2 to 34 per 100,000 population. What is important to note is that there is less female preponderance in childhood onset. That is, more male patients are likely to get affected by lupus and lupus nephritis in childhood age. So the female to male ratio is 4:1 or 2 up to 4:3. This childhood onset disease is more aggressive with a higher disease activity. There is high incidence of renal involvement particularly, and renal involvement has been shown to occur as high as up to 80% of the cases, and most of these occurrences occur within first 2 years. And as like adult lupus, African Americans and blacks have more disease, severe disease activity as compared to Caucasians. 10% of these patients will progress to CKD stage 5 despite best of your therapy within first 10 years. So we have to be careful about that. And the standardized mortality rate is also almost 3 times in childhood lupus and lupus nephritis as compared to non-lupus patients. Now pathogenesis is similar in childhood and adult. Only difference what has been reported is what is the role of genetic, because we know that lupus is a complex disease. There is complex interaction between gene as well as epigenetics and other phenomena. But in childhood onset, what has been reported is that many cases are monogenic in origin, and 7 to 8% of all children as compared to 1 to 2% of adulthood will have monogenic disease. There are more likelihood of affection of siblings. If one sibling is already having lupus or lupus nephritis, there are higher chances of other sibling being affected, and the concordance rate is also among monozygotic twins have been reported to approximately to be 40%. So this is difference in the pathogenesis between adult and childhood. Now we all know that EULAR ACR criteria have come up in 2019 and 2020 as a classification criteria, and they have replaced previous ACR and SLIC criteria. But how does these criteria perform in childhood onset of lupus nephritis? And this was a comparison between 3 criteria of ACR 1997, SLIC and ACR EULAR in childhood onset lupus nephritis, and what they have shown is that they are more sensitive but less specific. So we may be picking up non-specific cases if we are using these criteria in childhood, and what has been proposed, and it has to be validated, that rather than cutoff of 10, which we keep in adult patient, we should be keeping a cutoff of 13 for EULAR ACR criteria if we are implementing these in childhood lupus patients. And other things like disease activity mark indices like SLEDI, SLE responder index, BILAG, and SLIC ACR disease activity damage index, they all have been validated in childhood lupus also. So you can very well use these indices. And then also there are certain health quality questionnaires which have been validated in childhood lupus. And if you are keeping these patients on a longer follow-up, especially in registry data, these are the scoring systems or indices which you can use. Now, what are the differences between clinical manifestation of childhood and adult? As I have said earlier, they are more aggressive, and there are more chances of having renal involvement. There are higher chances of having cardiovascular involvement, and higher chances of having neurological involvement. And also this was a big comparison of more than 10,000 of where around 2,000 were childhood and remaining were adult, and they have compared clinical features, and this has been reciprocated in this article. And also what they have reported is that the hematological manifestations are also more common in childhood onset lupus. If we talk about lupus nephritis and what is the distribution of class of lupus nephritis, there are various publications from India as well as from abroad that class 4 with or without class 5 is the most common class of lupus nephritis, affecting as high as 50 to 60% of cases, and remaining are class 3 and class 5. So just like adult, they are having a similar distribution of lupus nephritis. Now coming to management. So management, some of important aspects have already been covered by Dr. Sujata. So it is a multidisciplinary approach. It should include pediatric rheumatologists and nephrologists. It should also include, because there are, and I am going to show you what other aspects of important management issues are there in childhood lupus nephritis. So we should also involve psychologists, nutritionists, physiotherapists, social workers, and other people. There are certain general things which you should be advising to all childhood lupus patients, like use of sunscreen, very, very important, which we often ignore in our busy clinical practice, because when the flare occurs, it almost always starts from skin. So they have to use sunscreen 2 to 3 times a day. They should have a well-balanced diet, salt restriction, control of hypertension, regular physical exercise. Immunization we will talk about in detail. There should be counseling regarding drug adherence and psychosocial support. Now, Dr. Sujata has said about American College of Rheumatology, but the similar recommendation is by KDIGO also, that the management of childhood lupus nephritis is in a similar manner as you will be treating an adult patient with special consideration to certain area which we'll be discussing about. So if you are dealing with class 1 or 2 lupus nephritis, so unless there is a significant proteinuria, you will not be giving them any steroids, you just be managing them as like use of ACE inhibitor, ARBs along with HCQS. However, if they have significant proteinuria, you can try giving them glucocorticoids, and if they are not responding, you can give them immunosuppressive therapy. Now, class 3 and 4, which are proliferative lupus nephritis, there are 2 guidelines which are specific to pediatrics, and these are CARA guidelines and SHARE guidelines, and both of these have not specifically mentioned one regimen over other. So what they have said is that you can use monthly cyclophosphamide regimen, you can use 15 days, that is urolupus nephritis regimen, and you can use mycophenolate mofetil. And these are the doses, like if you are using monthly, you start with 500 milligram per meter square, and you can go up to 750 milligram per meter square. And if you are using mycophenolate mofetil, then the dose is about 1200 milligram per meter square, and maximum dose which has been recommended is 2 to 3 grams. And this is a wonderful review article which has been published by Dr. Arvind Bagga's group just last month. And what they have summarized kind of what are the guideline recommendation and what is the practice recommendation, and what they have come up is that if you are dealing with class 3, 4 lupus nephritis, initial methylprednisolone pulse followed by oral steroids, and then you decide depending on what is your preference and what is patient preference, you start with either cyclophosphamide or mycophenolate mofetil, and then you assess at the end of 3 months. Now they have said that if patient is not responding, and this is what Dr. Sujata has also said, that if the patient is not responding at the end of 3 months, they have to be switched to alternative regimen. I think that is difference between adult and childhood. We don't switch to regimen unless they are worsening. In adult lupus nephritis, we only switch regimen if they are worsening, but in this flow, they have said that if they are refractory within first 3 months, you may be switching this therapy. So you can switch, if they have received cyclophosphamide, you can switch to mycophenolate mofetil and vice versa. And at the end of 6 months, then you try alternative regimens like use of cyclosporin or tacrolimus or addition of rituximab. I think what other thing was difference is that these patients are maintained according to this flow. The maintenance dose of steroid, what they have mentioned is 7.5 to 10 milligram, which I think is little bit high. We can maintain them on 5 to 7.5 milligram, which is what guidelines have also said to reduce the toxicity of glucocorticoids. And this was a meta-analysis like what are the differences between various kind of induction and maintenance regimen, and what they have shown is that both the regimens, whether you are using mycophenolate mofetil or you are using cyclophosphamide, they work equally well in childhood lupus nephritis. And so you decide according to the patient severity of the disease, preference of the patient after discussing with them, as well as your preference. Coming to rituximab, a nice case series by Dr. Sujata, where they have used rituximab in childhood lupus nephritis. So there was a cohort of 225 patients, and 17 of them were given rituximab. So there is data that rituximab can be safely used in childhood lupus nephritis with a relatively good outcome. But again, these are to be used only if they are not responding to your first or second line of therapy, that is cyclophosphamide and mycophenolate mofetil. And these are other reports of use of rituximab. There are various reports, so patient number varying from 11 to 50 almost, and they have used rituximab for variety of indications, and they have shown good outcomes with rituximab. There was a question regarding belimumab. Can belimumab be used in childhood lupus? Certainly it can be used, and there was a randomized trial which was known as Pluto, which was specifically for pediatric lupus. And what they have shown, and they have compared it with the Bliss trial, Bliss 52 and Bliss 76, is that the response in childhood lupus with belimumab is as good as in adults. So the SLE responder index at week 52 was significantly reduced as compared to placebo. This was over and above your standard of care, that is mycophenolate mofetil, as well as at the end of the SRI-6 at the end of 52 weeks was also better, and they reduced the chances of flare. So belimumab can again be safely used in childhood lupus nephritis. HCQS, very, very important. Don't forget all your lupus, irrespective of lupus nephritis or not, to put them on HCQS, a safe drug, effective drug to prevent future relapses. The dose is 5 to 6 milligram per kg per day. And what you should also remember is that you should be monitoring these patients for toxicity in terms of retinal toxicity, because it can be reversible in about half to 1% of cases. So what is recommended is that every 5 years you should be evaluating their retina for retinal toxicity. And HCQS is almost lifelong in these patients. What about glucocorticoids? Because these are childhood, they are growing people, they have bones which are growing, so there is significant steroid toxicity which occurs in childhood lupus. So it is seen more if the steroid dose is more than 7.5 to 10 milligram per day, and that is why I said that it is in the maintenance you should be using about 5 to 7.5 and not more than that. And they also not only have effect on bone health, they also have effect on their gonadal system, and it has been shown that patients who were on higher doses of steroid have more delayed puberty onset in childhood, both males as well as in females. And this was a very nice paper where they have compared childhood lupus versus adult lupus and what was the steroid toxicity irrespective of the duration. So the duration was same. So you can see if the duration of steroid exposure is 0 to 10 years versus 11 to 20 years versus 21 to 50 years. So duration is important. But what is also important is in the same duration, the child will have more toxicity of steroid. So you can see this is adult and this is child. So every duration, the childhood exposure to glucocorticoids will have more toxicity as compared to adults. Now, if you have managed, what are the outcome results with childhood lupus and lupus nephritis? And again, this is the same systematic review by Dr. Bagga's group published this month. And what they have shown is that the complete remission at the end of 1 year is about 60%. Partial remission is about 27%. So if you look at overall renal response at the end of 1 year, it is about 87%. And what is difference, and this has been noted in adults also, that in lower and middle income group, we have more complete remission as compared to partial remission as compared to Western. And this has been shown both in childhood as well as in adult studies, that complete remissions are more in developing countries rather than as compared to developed world. But what is surprising is that even if we have better complete remission rates, but our outcomes at longer term outcome like 10 years or 20 years are worse than what has been reported from West. And this is same kidney survival, same paper. Kidney survival was at the end of 5 years has been reported in the range of 80 to 90%. And this was what I was saying you, that our long-term outcome are inferior as compared to what has been reported from West, despite we having better complete remission rates in short term. And patient survival was also in the range of 80 to 90%. Most of the patients who die, and this is the mortality data, most of the patients who die, almost 50% of these patients die because of infection, and that is very good, important thing to remember. Then don't overtreat, don't be very, very aggressive with the immunosuppressive therapy, because you will be losing your patient to infection rather than disease activity. So 50% of patients die because of infection, and about 20% of these patients dies because of lupus activity. And these are other paper, and these are kind of follow-up. So up to 20 year of follow-up data is available from Western world, and this is similar like what I have said earlier, that about 10% of these patients will progress to CKD stage 5 by the end of 10 years. And so the renal survival is about 80 to 90% at the end of 10 years. What about India? So this is a paper from SGPGI Lucknow, where they have followed about 200 patients. This was a retrospective analysis, childhood onset lupus for a long-term follow period of 13 years. And the biopsy series was similar, like majority of patients had class 4 lupus nephritis. And the data from SGPGI has also shown that about 7 to 8% of their patients progress to ESRD by the end of 10 years. And this is comparison of SGPGI study and other centers, including one from PGI Chandigarh, where what they have reported is that majority of, even in India, 50 to 60% will have class 4 lupus nephritis, and the 10-year survival, renal survival will be about 80 to 90%. What are predictors of poor renal and patient outcome are if you have more severe activity. If you have younger age of onset, more severe disease, like you have renal dysfunction at presentation or requirement of dialysis, you have class 4 or proliferative lupus nephritis, and you have flares, repeated flares. If you are having a long term, you will have a more severe outcome. What are other aspects of management? And these are very, very important if you are dealing with childhood onset lupus, lupus nephritis. You should not forget these other aspects of management. One is vaccination. So you can use, you should not be using live attenuated vaccine after you have started these patients on immunosuppressive therapy. So whatever, if time permits, if patient give you time, you complete your vaccination schedule before giving an immunosuppressive therapy. However, dead vaccines, non-live vaccines can certainly be used in childhood onset lupus nephritis, irrespective of whether these patients are on immunosuppressive therapy or not. Non-adherence is very, very important issue in childhood onset disease, and it has been reported to as high as 50 to 60% of cases of childhood will be non-compliant, and 97% of pediatric rheumatologists have reported they have encountered significant non-adherence in their practice, and this non-adherence actually affects the patient's self-esteem and self-management. And although people have advised that we should be using something like medication reminder, like in last web-based education and medication reminder, this improves their adherence. But what has also been reported that if you put this patient on these kind of reminders, they affect their mental health, because they will always be having this always be bugged by this continuous reminder. Although their adherence will be improved, but they will have significant low self-esteem. So mental illness, mental health is another important area which is neglected, and it has been reported that depression and anxiety can occur in up to 1/3 of patients. And so that is why when in the beginning I said it should be multidisciplinary approach, and it should also include your psychologists and psychotherapists, that these patients should be counseled regularly regarding what is their adherence, what is their mental issues, and scholastic performance and things like that. Another important area is bone health, because these patients are on long-term steroids and also on other immunosuppressive therapy which will affect their bone health. What is recommended is that you should be doing an DEXA scan on these patients on a regular basis, and try to improve their bone health by giving regular calcium supplementation and regular vitamin D supplementation, and try to keep vitamin D levels more than 50 nanomole or 20 nanograms. Gonadal health, another important area, especially if they have crossed the pubertal age. If they have achieved the puberty, gonadal issue come up, because gonadal dysfunction occurs in these patients, both in males as well as in females, and it can be permanent or irreversible in some proportion of cases. So what is recommended is that you should be ideally evaluating their hormonal profile as well as radiology, like especially in females you can do their ultrasound pelvis, ovarian follicular count, and keep on monitoring these counts and what is happening on a long-term basis, so that you can pick up these cases on an early basis and manage them accordingly. There was a question whether we should be using GnRH. You can certainly use GnRH, you can certainly go for ovulation preservation and sperm preservation, but what is important is that it will not be of much use, especially GnRH, because if you are using GnRH, it has to be given at least 3 weeks prior to the giving of your first dose of endoxin. So in subsequent doses, it may be fine that you have time, but in the first dose, when you have to give immediate pulse of cyclophosphamide and you can't wait for 3 weeks, you can't be using this. So it's almost impractical to use. But certainly in subsequent doses, you can use this GnRH analog, and if the cost permits and patient is willing, you can go for ovum and sperm preservation. Now, another important neglected area is pregnancy, and we often ignore, and there are a lot of publications that these are adolescents age group, and they are sexually active, and mean age of first sexual intercourse was reported at 16. So they should be counseled regarding this. They should be advised for contraceptive if they are sexually active, and you should be avoiding unnecessary pregnancy, because pregnancy is going to affect their outcome, especially the long-term outcome. So again, a neglected area, but should be taken care of, especially if you are dealing with this adolescent kind of people. Similar to adults, like you should be avoid using cyclophosphamide and mycophenolate mofetil if they have already become pregnant. Cardiovascular health, because they are long-term patients, cardiovascular health is going to be affected. So 5 things you should be looking at, and you should do these 5 things on a regular basis on 1 to 2 year interval. That is hypertension, body mass index, diabetes mellitus, smoking, and serum lipid level. And there are a lot of safety data which is now available, that you can certainly use statins in your childhood patient if you want to control their lipids, and there is no long-term toxicity of statins with these in these patients. And finally, there is concern about malignancy, because they will be surviving for a long period of time. So there has been report that significantly, like 4.7 times higher incidence of invasive cancer and 5.2 higher times of hematological cancer. So a regular screening protocol for cancer should be devised if you are managing these patients on a long-term basis. And importantly, transition of care from childhood to adulthood, because this disease will continue to go on till adulthood. So transition of care, you should always be discussing these issues with your patient and their caregivers, in detail that now it will be transitioned from childhood care, like from pediatric rheumatologist or nephrologist to adult rheumatologist or nephrologist, because what has been reported that during this transition of care many flares occur if you are not discussing properly with these patients. So a proper transition should be taken care of. Kidney transplantation can certainly be done. There are no pediatric specific outcome has been reported, but what we know from adults that disease recurrence is very, very rare, less than 10%. The outcomes are as good as non-lupus nephritis patients, so kidney transplantation can be offered if these patients have reached CKD5D. So to conclude, childhood lupus, as I have said, is a chronic inflammatory disease and it is a more aggressive disease. And these patients are a very long-term follow-up, unlike adult onset lupus disease. So it has an impact on holistic growth as well as development of child. So it should be treated. As far as immunosuppressive therapy is concerned, the treatment is similar to what has been recommended in adults by various guidelines. But very important, should be you should take care of other aspects of their care, like their bone health, their mental health, their non-adherence issue, their vaccination issue, their cardiovascular issues and things like that. Don't forget about this, because this is a long-term disease. Chances of long-term complications are more, and that is why you should be screening them and managing them properly. Thank you for your patient hearing. Happy to take any questions.
Thank you, Professor Rathi, for your exclusive and crispy presentation on childhood lupus. And in your talk, you cover almost all the topics related to childhood lupus. So there, I think there will be very less scope for any questions, but still, if there is any question or comments from our audience, it's open for any questions or comments. Mike, please.
Sometimes what happens is because these patients are having fever and they'll be showing some lymphadenopathy in the chest x-ray or some retroperitoneal lymph nodes, they are started on ATT from outside. And once they come to us, we diagnose lupus. So what about this ATT that they are on for last 1 to 2 months? Should we continue it? Should we stop it and then start the pulse therapy? Because
So I think this is a very common thing. We also note that many of these patients will be receiving ATT because they will be misdiagnosed as tuberculosis. But once you have confirmed your diagnosis that this is lupus and there is no tuberculosis, I don't think there is any justification of continuing ATT in these cases. You stop ATT and give them therapy for lupus. But very common issue, I think, because of fever, unexplained fever, long-term fever, lymphadenopathy and things like that, they will be put on ATT. But no justification of continuing it.
Yeah, excellent talk, Manish. My comment is regarding steroids. Is there any move towards steroid sparing protocols? That's the first part, because steroids are not innocuous drugs. And the relation between osteopenia is actually cumulative dose related rather than the maintenance dose. There are several papers, including ours in nephrotic syndrome, where we found a direct correlation with the total dose and the changes in bone density. So, any move towards stoppage of steroids and moving?
So surely it is related with the cumulative dose, and that is why I have said that when you are using maintenance, don't use 7.5 to 10. It is not required. 5 to 7.5 is enough in maintenance. So that should be the dose. And steroid sparing, I think the world is moving towards rapid steroid tapering rather than steroid avoidance in, at least in lupus. There are steroid avoidance in ANCA. So rapid steroid tapering will be done if you are using certain newer kind of therapy, like voclosporin has been used with a very aggressive steroid tapering, and by the end of 4 weeks, these patients are on 2.5 milligrams of steroid. Similarly with belimumab and other biologicals which are being studied, they are studied that they are not going to replace your current standard of care. You will continue to give your mycophenolate, mofetil or endoxan, but what you are targeting is if we can aggressively reduce their steroid and just maintain them on 5 milligram or 7.5 milligram.
Related to this lymphadenopathy and SLE, many times I have seen the patients which have been misdiagnosed. Sometimes a patient has the Kichuki disease that comes in, and sometimes that have the similar necrotizing lymphadenitis, and that requires attention. And many times we used to treat this patient like SLE, go on treating. So we should have one differential diagnosis in the mind at that point of time.
Yes, thank you.
If I could, one very important thing is in the SHARE guidelines and even in the ACR guidelines, the initial dose of steroid has certainly come down. Earlier we were using 2 milligram, but now it's 0.6 to 1 milligram. There is a lot of work done in the UK about steroid sparing regime, which was done in adults by the Eisenberg group, where they used rituximab with IV steroid and mycophenolate with no steroid in between. And they gave this regularly every 6 months, but that group of patients had a very high risk of relapse. So we're not currently using that in pediatrics. I think a couple of more interesting things from a pediatric standpoint is, first of all, we need to monitor the growth velocity of these children. And this is one condition where growth hormone is relatively contraindicated. So we don't like to use growth hormone because the lupus can flare up very significantly. Secondly, I think it's very important, and something we don't do in our practice as much as we should, is screening lumbar lateral x-rays for these children, because many of them have silent vertebral collapse fractures. And then that group of patients we can give alendronate. I'd like you to touch upon antihypertensives, which we've not discussed in these patients. What is your go-to drug other than the ACE inhibitor? Do you use combination inhibitors and ARBs in your practice?
Okay, thank you for your very nice comments. I think the rituximab data which you were talking was Rituxi-Loop and Rituxi-Rescue trials, which was done by Liz Lightstone. They have not been replicated anywhere else, and that is why nobody is using rituximab with steroid sparing. As I have said earlier, it is steroid tapering, which is, and you have also said that, and guidelines have also now brought it down to 0.8 to 1 mg per kg of dose rather than initial higher doses. So what is recommended is you bring it down. Regarding lateral x-ray, I am not aware of that, but what has been recommended by guidelines is to do a DEXA on a regular basis 3 to 6 monthly and not do an x-ray, because if you do a DEXA, you will pick their bone health deterioration earlier as compared to their certainly every time we recommend these kind of things, we are adding to the cost of the management. So that is if your cost is permitting. Regarding your question on antihypertensive, I think the drug of choice is ACE inhibitor or ARB. There is no doubt about that. Combination of using of ACE inhibitor ARB is not recommended these days because there is no added advantage and there is worsening of hyperkalemia. So you should not be using this drug. If your blood pressure is not getting controlled on ACE inhibitor or ARB, despite you achieving maximum recommended dose, then you can start these patients on other antihypertensive therapy, which may include dihydropyridines. But not to forget, I don't know if there is any data of SGLT2 inhibitor, flozins in pediatric, specifically in pediatric lupus nephritis. But in adults, at least we have now started using flozins in nephrotic or in proteinuric kind of patients whose blood pressure is not getting controlled, because they will reduce their blood pressure as well as they will reduce their proteinuria. And especially in lupus also, we have now started a project where we are randomizing them to flozins versus no flozins, because as of now there is no data on lupus whether flozins should be used. But SGLT2 inhibitor is another important group of drug which will reduce their proteinuria as well as their hypertension.
Question regarding lupus nephritis. So when exactly do you label lupus refractory? Because I'm not aware of any consensus definition to label a case as refractory. And second, in such cases, should we consider plasma exchanges before considering retux or something, if it has been already labeled refractory, especially in low resource setting where patients cannot afford rituximab?
So certainly there is no consensus definition of refractory lupus nephritis, and to confuse more, there is a term which is known as non-responding lupus nephritis. So what is difference between two? So if you have used your first line therapy, say for example you have started this patient on mycophenolate mofetil, you have waited for 6 months, patient is not responding, you label this patient as non-responder, you don't call them refractory. After you become non-responder, you switch them to another first line therapy. So if you have started with endoxin, switch them to MMF. Wait for another 6 months, so total 1 year. If they have not responded even to cyclophosphamide and MMF, then you call them refractory. This is consensus definition. This is not by evidence-based recommendation. So this is how we define non-responder and refractory. And at the end of 1 year, if you have labeled them refractory, then you can start using calcineurin inhibitors and things like that, or rituximab. Plasmapheresis is of no value unless there is associated thrombotic microangiopathy or APS or APS nephropathy. Other than that, just in lupus nephritis, it is of no value.
Thank you.
If there is no more question, thank you, Manish, for a wonderful lecture. I think we have enlightened all of us. Thank you very much. We close the session.
I request all chairpersons and speaker for the memento presentation. So our next topic is C3 glomerulopathy, current understanding and management. To chair the session, I invite Dr. Omila Anand. She is Senior Consultant Nephrologist and Head of Department at Amrita Hospitals, Faridabad, Delhi NCR. Uh, I invite our next chairperson, Dr. Pankaj Hans. He is Head and uh, Head of Department of Nephrology and Kidney Transplantation at Ruben Memorial Hospital and Associate Professor, Department of Medicine, Patna Medical College and Hospital. I invite Dr. Mrityunjay Kumar, who is Assistant Professor, Department of Pediatrics at AIIMS, Raebareli. And Dr. Abhishek Raman, he is Associate Consultant Nephrologist at Jayaprabha Medanta Hospital, Patna. And I hand over the session to chairpersons for the next proceedings.
Good morning, everyone. Actually, Professor K.L. Gupta sir needs no introduction. He has been the former head of department of nephrology at PGIMER Chandigarh, and he has held several posts in the Society of Nephrology, like past president of ISN and ISOT. So without wasting any time, I hand over mic to Dr. Urmila for introducing the topic.
Professor K.L. Gupta will be talking on C3 glomerulopathy. I think this is an emerging area of interest for not just adult nephrologists, but for pediatric nephrology. And I'm sure, as Dr. Pankaj Hans says, that we don't need any introduction of Dr. Gupta, and let's go ahead and listen to him.
Thank you, Chairpersons. First of all, it's my pleasant duty to thank Dr. Hemant and his colleagues, Dr. Om, Dr. Shashi, Manish Krishna and others, for hosting this meeting and inviting me. I would just like to take an opportunity to say that 6 months back when I visited an ISN assignment, I was told that such a meeting is coming, and I never imagined that this meeting was going to be such large and such a great academic and social event. Since yesterday I have been enjoying every talk. Anyhow, I come to my assigned duty of discussing C3 glomerulopathy. As you know, C3 glomerulopathy is defined as a form of glomerulonephritis. It's a rather a rare disease wherein we have proliferative glomerulonephritis with C3 dominant deposition of the order of 2 or greater magnitude as compared with other immune rectitants. Basically, this disease is interesting from the point of view that it is associated with a very high incidence of renal failure, and it's difficult to treat, and if you do transplant, recurrence also is very common. Now, what are the questions that we need to answer? Is the C3 a new disease or a new terminology of an old definition? What is the role of complement in health and disease? What are the pathological spectrum of C3 glomerulopathy, and what are clinical manifestations, how to evaluate and treat the disease, and what are the problems in transplant patients? Basically, this disease has been derived from the old, what we call membranoproliferative. If you see here, membranoproliferative has to be understood in the context whether patient has immune complexes along with C3 glomerulopathy. In that case, this is immune complex mediated MPGN, which can be polyclonal or monoclonal, and can be secondary to infection, can be autoimmune, or can be related to paraproteinemias. On the other side, if you have only C3 deposition, no immune deposits, then it's C3 complement mediated disease, and there are two diseases in that, that is dense deposit disease and C3 glomerulopathy. So these are related because are caused by alternate pathway of complement activation dysregulation, and that's so here we see that under the umbrella of C3 glomerulopathy we have dense deposit disease and C3GN. And if I just take you to old definition of MPGN, there are three, Burkholder had defined in three types, MPGN type 1, where we had subepithelial deposits and mesangial proliferation, and then type 2, where we have intramembranous deposits. We used to call ribbon-like pattern. If you see on the electron microscopy, that's called dense deposit disease. And type 3 was when we had subepithelial, subendothelial, and sometimes epimembrane deposits. So what is C3 glomerulopathy now is dense deposit, that is type 2 is dense deposit disease, and type 1 and type 3 may be representing C3 glomerulopathy, glomerulonephritis. So this is what I already said that, and if you look at on the basis of immunofluorescence and deposits, MPGN has immunofluorescence positive, has immunoglobulin deposits, and of course, and dense deposit only has immunofluorescence positive, C3, as well as deposits. C3GN only has immune deposits. Sorry, not it's only C3 deposition. And this is another picture showing you on the left side, it is MPGN type 1 and the type 2. And this is a morphological picture of mesangial proliferation and then membranous proliferative with double tracking and the immunofluorescence here. There was a very good paper which came recognized first time the primary glomerulopathy with the C3 deposition in 2007, wherein they described this entity, and out of 19 patients, 7 had association with C3 nephritic factor and 3 had with the complement factor H, 1 had with I, and other with membrane cofactor proteins. So that was the first time they described. And what is the epidemiology of C3? It has been estimated that there is an incidence of 1 to 2 per million population and 2 to 3 per million population prevalence. And as regard the relativity, some studies have described that dense deposit tends to be more common than C3GN. As for the age of onset, dense deposit disease occurs earlier in the younger people, and C3 glomerulopathy in the later age group. Gender-wise, there is no difference. Geographic distribution, not much, but particularly complement factor H-related nephropathy has been found to be in Greek seprites. Coming to pathogenesis, basically this is a disease wherein we have C3 deposition, and it is secondary to dysregulation of alternate complement pathway, and this occurs because of increased activation of C3 convertase and decreased regulation of the C3 convertase because of decreased functional activity of factor H and factor I. So here we look at this this diagram. Pointer, so if you see here, I'll try this thing. We have three pathways of activation. We have got classical pathway, wherein we have complement factor 1, 4, and 2, and here we have the degradation products coming here, and then lectin pathway, they combine to form what called C3 convertase, wherein we have got complement factor 4b and 2a. Then that further converts C3 and C3a and 4 another further dose, and this is called C5 convertase. Similarly, on the alternate pathway, we have factor B and factor D, which act in presence of bacteria and viruses. They will activate, split 3 into 3A and 3B, and this 3B will be converted into C3 convertase. And this C3 convertase further splits C3, the cleaves further, and then leads to more addition of C3b to the C5 convertase, C3 convertase lead to C5 convertase. Now, what are the controlling factors? There are controlling factors are factor H and factor I, as far as the C3 and C5 are concerned. And there are more, we have membrane cofactor proteins, that is MCP, and then we have got complement regulator protein and decay delay accelerating factors. Again, same thing, how the dysregulation occurs. The important steps shown here are the C3 convertase formation, C5 convertase formation, and activation of C5 into A and B, and that's a very strong immune inflammatory marker, and this leads to formation of membrane attack complex C5b to 9. So, and there is further joining by the cytolytic actions, neutrophils and things like this initiate the inflammatory cascade. Now coming, what are the main problems in this is what happens? Basically there is a increased activation of C3, and this is further helped by participation by properdine and others, and there's decreased controlling action by factor H and factor I and membrane cofactor. And here if we see C3 convertase is the main thing, but crucial factor which plays the role. And so what are the regulatory proteins? We have got those which regulate the complement in the form of complement factor F, complement factor H, complement factor I, and then of course the membrane cofactor proteins as mentioned here. I just highlighted these because I'm discussing this in context of therapeutics. There's complement regulator 1, and then we have got membrane cofactor protein and decay accelerating factor. So this is in pictorial demonstration of how the complement regulators act in the fluid and on the cell surface. Then these are the different antibodies I discussed in context of complement regulators and autoantibodies. So what are the causes of these? Why these alterations occur? There are genetic causes, there are acquired causes. Genetic causes is because of loss of function, because there is a decreased decreased production of factor H and factor I, and then similarly gain in function, more of C3 convertase action is there, and acquired factor can be mutations in these different proteins. Coming to pathology of C3 glomerulopathy, it can present in different patterns as shown here: mesangial proliferation, membranoproliferative, as well as diffuse proliferative, and correspondingly we have got these immunofluorescence seen here, C3 deposition. Coming to dense deposit disease, it basically occurs in younger children, but can occur in some adults, and it is different patterns on histopathology can be membranoproliferative, where we have mesangial proliferation and then double tram track appearing of the basal membrane. You got thickened membrane is there, and then you got mesangial proliferative, diffuse proliferative glomerulonephritis, and crescentic glomerulonephritis. These are different definitions here. And then what are the features in C3 glomerulopathy? Again, this occurs little older children and the adults. Mean age is 30 years. There is no difference in male and females, and of course the presentation can be with the as shown here, nephrotic, with hypertension with proteinuria. And just to say, these are different histological patterns that you can see again through repeat: mesangial proliferative and membranoproliferative and crescentic, and this immunofluorescence. And the important thing to show on electron microscopy, this dense deposit is, if you see here, this cerebral-like deposits intramembranous, and then C3GN, this is subepithelial and subendothelial deposits. The clinical presentation of this can be with there's some differences. Dense deposits are present more often with the nephrotic syndrome. C3 nephropathy, C3 glomerulopathy are more often present with the hypertension, renal failure, and as far as the lab parameters are concerned, we have got alterations in the C3 decrease in both the cases. It is 100% in dense deposit disease and 48% in the C3 glomerulopathy. C3 nephrotic factor is very commonly associated with the dense deposit disease, And of course, hypertension and proteinuria can be seen in both the cases, renal failure again, both the cases. 50% loss of renal failure as well as recurrence in both the cases there. And these are the tables showing the differences. This is just a repetition of what I said. Basically, the point is that C3 GN is little older and dense was earlier. And if you see in the lab parameters, nephritic, the C3 nephritic factor is more often associated with the dense deposit disease. C3 convertase is more with the dense deposit disease. C5 convertase activity is more with C3 GN. And factor H related autoantibodies are in both cases. Soluble membrane attack complex is more often seen with C3 glomerulopathy. So these are extra renal manifestation. If you see on the left side, we have got drusen bodies in the retina, Busch membrane. The deposits are there, and they will be acquired, partial lipodystrophy, Barraquer-Simon syndrome, loss of subcutaneous fat. These are associated more with dense deposit disease. Coming to another entity, just you should not forget about complement H factor related nephropathy. This has been seen mostly in Greeks of Cypriot origin. Incidence is 1:600. The important differentials are that this is associated with both microscopic as well as macroscopic hematuria, and it can occur whenever there is an episode of pharyngitis, and often it is not that much progressive as the renal failure is concerned. Sometimes glomerulopathy can be related with the polyclonal gammopathy, monoclonal gammopathy, as more of paraproteinemias, but this doesn't come here in discussion today with the children and kidney disease. It's more often, elderly people, if you have this thing, we should suspect this thing. Any CA3 in elderly age, we should rule out this thing. Coming to our Indian experience, we had a publication from Chandigarh. This was first time in 2007 to 2012. We had 31 patients. Again, dense deposit disease and C3 were there. They are younger as far as the dense deposit concerned, and 50% loss of renal function was there. Then this later in the study came, this was in 2020. Again, herein we have 115 patients, wherein we demonstrated again different patterns. And this is now 2022 unpublished data. Over the year, we have found more cases in PGI. And this is showing you the different patterns of presentation. These are different pathological patterns that we see in these people. And clinically, these patients, nephrotics are more common with dense deposit disease. And nephritic nephrotic is both in both the cases. And nephritic with the hypertension is C3GN. Workup of these cases, all this is shown here. C3, C4 levels need to be done, factor H, factor I, and we can even estimate other factors, C3 nephritic factors. Coming to the treatment of C3 glomerulopathy, well, first of all, we should evaluate what are we doing. If we encounter any patient with the microhematuria, with proteinuria, we always tend to think of either a primary or secondary nephrotic syndrome. And if we find that there are indicators, and we do all tests like ANA, ANCA and all that, and then if on C3 is low, then we go further demonstration, whether obviously we'll do a kidney biopsy, and if kidney biopsy shows you changes of inflammation and the documentation is immunoglobulins, and C3 we go in terms of immune complex mediated disease. If not, then we think in terms of C3 glomerulopathy, which could be dense deposit disease. And accordingly, if patient has immune complex mediated disease, then we'll go more for those immunosuppressive drugs, the mycophenolate and cyclophosphamide. But if we find it is C3 deposition disease, then in the subsequent protocol I'll be telling you. And this is what we do in all the patients with C3 glomerulopathy, that there should be optimal control of blood pressure, and we should control their, obviously drugs of use are ACE and ARBs, And then we need to maintain their nutritional status, lipid control. And if there's a moderate involvement in the terms of proteinuria more than 500 milligram or the slight rise in the creatinine, we should think in steroids and mycophenolate. As for the different drugs which have been used in C3 glomerulopathy, there's a long list here. ACE and ARBs for hypertension, lipid-lowering drugs, and of course immunosuppressive therapy with the steroids, both the standard oral and pulse, as well as mycophenolate, role of plasma exchange. I'll just touching on this. And most important, specific to C3 glomerulopathy are the role of anti-complement therapies, that is C5 in anti-C5 factor, and then other proteins which we were just discussing. So as per the K-DIGO recommendations are that patient with mild disease, we just need to leave it. But if there is patient with the moderate involvement with proteinuria of 0.5 to 2 gram, we need to treat with the steroids and mycophenolate. And since the basic mechanism of defect is the complement dysregulation, we should try to give anti-complement therapies as far as possible. So treatment of C3 glomerulopathy includes mycophenolate, and this is showing the benefit of this. In PJ Chandigarh also, we had a trial with 17 patients in whom we tried mycophenolate, and it's shown here. Can you help me? It's shown here. These patients with mycophenolate had better outcome in the term of 65%. Coming to plasma therapy, there have been anecdotal reports of its utility in these people, and in our institute we had used it in terms of post-transplant recurrence, and these are the studies, but benefit was not much. Now coming to specifically to complement inhibitors. As we know the mechanism, just to revise classical lectin and alternate pathways, herein we have C3 convertase and then C5 convertase, and important is the C5, complement factor H, complement factor I, factor D and factor B and property. So accordingly we have got these diseases, whether we have got immune complex mediated C3GN, dense deposit disease, and here are the drugs which I will just touching on these later. Most important drugs that I need to discuss here is eculizumab. Most of the studies have shown its benefit because of its anti-C5a activity, and this drug is good if you use in early disease. Then it can have a better outcome. And some studies, of course, have shown that even in patients with advanced disease, it does reduce inflammation, and it helps in early reducing their renal failure development and delaying renal failure. The dose that to be given is 900 milligram IV weekly for 5 weeks, and then 1200 milligram every other week afterwards. So as against long-term beneficial, this just latest study in January 23, herein they had a study of these patients. Basically they found 14 patients they have reported. In 11 they had classical, they gave treatment, and in 3 they gave standard of care. And here they found the beneficial effect in terms of stabilization of creatinine, that is their GFR was maintained in the range of plus minus 30% in this percentage of cases, and in 6 cases, and in 5 it was negative outcome, and 1 out of 3 in standard of care had a negative outcome. So they say it's a limited role. Then there are other studies which is like other future therapies, recombinant proteins as far as the anti-complement therapy is concerned. Then this this soluble complement regulator 1 antibodies, this is another paper here. Then we have got factor D inhibitor, daricopan, and then there's one comstatin, again a complement inhibitor, again has been studied. And this is just a report which came last year. uh, iptaconstantin, this again factor B inhibitor. So these are the different proteins which can be used. Coming to transplant, this is a very bad scene. I have personally seen so many patients. We did transplant, and this remember vividly 4 or 5 patients wherein outcome, the recurrence was very fast, within period of 1 to 3 months, and their outcome has been poor. And this was a study from our institute wherein we had these number of patients, and uniformly we had a bad outcome. This is list of the patients. So comparison of a PGI study with others, definitely our patients were younger, and they had more severe presentation, outcome was worse. Now coming finally to the end of my talk, this C3GN represents a form of nephritis wherein we have C3 deposition in the form of dense deposit disease, and C3GN, it's associated with the extrarenal features, especially in dense deposit disease, and we need to recognize this by early biopsy and demonstration of the specific C3 deposition on immunofluorescence. And treatment with the steroids and mycophenolate in moderate disease is okay, but use of complement factors also is very important in patients with C3 disease, especially if used early. And of course, there are other treatments under trials. With this, I end here. Thank you.
For an excellent overview of a very difficult topic in our country, especially where we don't have anything much to evaluate and even treat. I just wanted to, because it's a pediatric audience, and we believe and we see the common concern for us is to differentiate between a post-infectious glomerulonephritis and a C3 GN. So will you just elaborate how, and maybe we take opinions of pediatricians?
Very important, Dr. Urmila. This needs to be this very important differential diagnosis. Post-infectious nephritis, we can have C3. The thing is that in C3, they after 12 weeks, the complement level would come to normal in patients with the post-infectious nephritis, whereas it will persist to be low in patients with the C3 deposition disease. And of course, there are other factors, other things, you see morphological, and if electron microscopy, especially there, definitely that will differentiate.
Yeah,
any comments from pediatricians?
Yeah.
3 months titers of
Ma'am,
C3.
actually, I completely agree with you. And as pediatric nephrologist, we many times confuse. And conventionally, we don't biopsy in PIGN. But if it's a persistent IRGN, sometimes we biopsy. And many times we get DPGN picture on LM with a predominant C3 deposition on IF and without any predominant immune complexes. But in those cases, probably I think we can continue treatment with as a atypical PIGN. And many times we evaluate on the lines of other complements like CH50 and CF and other complements. I think ma'am will elaborate further how would you approach.
Overall, C3G is a bad disease. As you have also said that we don't have too many handles to how to manage them. But the clues to diagnosis, sometimes even at onset, if you have a very low C3, we know it's a C3G. I mean, you have a child presenting like a PIGN, but you have a C3 value of something like 6, 8, 10. You worry around C3G there. The second thing is like you tend to have patients presenting with more adverse presentations like crescentic glomerulonephritis, a bad renal failure right at presentation. But the other entity that you see is like patients presenting as nephrotic nephritic so-called presentations. And they are also very difficult situations, but we tend to biopsy them early on then.
In PIGN, not.
Yeah, we do always.
In general pediatrics, we have so many patients coming with proteinuria, hematuria. In our general ward, in resource-limited setting, how you will suspect the C3 glomerulopathy? Like in post-streptococcal glomerulonephritis, we have told about the complement returning to normal after 12 weeks. But many patients of renal disease coming to general pediatrics, with these symptoms, how we can suspect it for this, ruling out this
I think
C3
if you are
glomerulopathy in
practicing,
resource-limited settings.
if you are a general physician or a pediatrician, any patient with proteinuria or hematuria, of course you will rightly suspect streptococcal and other infection-related disease, but you must consult a nephrologist. And if any time patient comes to me as a nephrologist, I will always do this complete profile of sheath complement profile, and particularly even female, little older, even ANA and other all these parameters are important. If the elderly person, older person, I will send ANCA, anti-GBM, all this. So immunology has a very important role, and these are the indicators that this is probably not a straight, simple post-traumatic bronchitis. But then you have got other like ASO titers, those are old things we don't do. But I think in every case we have to do complement and Dr.
Yeah.
Prasad.
We have no confusion if we have low C3 and after 8 weeks it becomes normal. So that is very clear. Problem is there with resolving PIGN. When PIGN is resolving, you do biopsy, you see only C3 is there, and many times normal C3 can be there in C3GN as well. So that is the most confusing point, where then you might have the nephrotic proteinuria. Even electron microscopy, some epithelial humps can be seen in both. So that does not help out. So only thing is that if you show more signs of recovery, no response, then C3GN, if you have, because no clue as such that indicates that probably this is C3GN or this is resolving PIGN. So that kind of confusion continue on.
I don't think there is so much of confusion. It all depends person who is reporting. I mean, because in PGI we used to get very often the suggestion that to rule out C3, and especially if in centers, advanced center where the facility is electron microscopy there, then further all the doubts are taken up. Yes.
So I will take the lead when just Narayan left, the nephritic presentation and younger age group. Atypical PIGA not resolving, we do a repeat biopsy after 12 weeks. If the C3 is persistent, and we would, at that point of time, we take the hint that this persisting C3 and the typical picture of mesangial as well as sort of DPGN persisting, we call it C3GN.
Yes, we have been teaching our students that when you get a patient who is a nephrotic, either younger or older, doesn't matter. But if you find, we normally don't do biopsies in state stop forward suspected case of PAGN. But if you find that over the time complement level is low, definitely, and persistent hematuria protein there, definitely you have to do a biopsy. Sir?
Yeah, you're right. Actually, if there is a nephrotic picture, you biopsy straight away. You pick up crescentic changes and all that. You need to treat them aggressively, strongly right at the beginning. Do not wait for too long. If it's just typical like post-streptococcal, you might wait not too long. Important thing is to biopsy early on, to safe procedure.
Thank you,
sir. Sir, in absence of eclogimab in our country, it is not available. For severe disease, what is your take-home message, sir?
What is it?
Eclogimab is not available in our country. So in severe cases of this C3GN, what is your take-home message? How to treat such patients?
In PGI, we tried all these things, steroids, cyclophosphamide, methylprednisolone, and I think ultimately, I have no answer to that question. We have to wait the time when we can afford the eclogimab come because with cheaper rate.
Any role of bortezomib in such cases?
Bortezomib? I don't know. I don't think it has been mentioned. That is an anti-B cell therapy. That doesn't come here. Anyone can say on bortezomib?
Effective therapies are not available. So that is a bad scene, and one of our responsibilities as a nephrology community is also to raise demand for making these therapies more available. The second thing is to let you all know that new trials are now entering development phase. So new phase 3 studies are coming our way, and I request, rather urge all of you to enroll your patients on those trials. That is the only way they will have access to effective therapies. Enrollment of patients in clinical trial always raises the standard of care, no matter which arm of treatment they will go to. Even if they go to an arm, mostly you don't know, because these will be randomized trials, and you might be blinded, or in some cases you may not be blinded. But even if they go into the control arm, they will receive the best standard of care at that time, at least, even if they don't receive the study drug. So that is what we should do: raise demand, and second, participate more and more in clinical trials.
Before I leave, I would like to say, like the way we had experienced PGI, I mean, way back in 2014-15, we didn't talk about it. Only after the studies came, then we started analyzing our old biopsies. So now what I want to say is, all pathologists should be very, very keenly looking for this entity, and we might be, better helped in such cases if we are aware of such an entity there, and we do all these tests, and especially immunological test and evaluation in all patients with the presenting with the glomerular disease should be done.
Thank you, sir, for such an insightful talk. If there are no more questions, I would like to close this talk.
Thank you.
So our next session, sorry. Our next session will be a virtual one by Dr. Michael Molina. He is available with us on the virtual platform, and the topic is the changing paradigm of HUS, hemolytic uremic syndrome, the experience of UK HUS service. To chair this session, I request Dr. D.S. Baduria. He is Professor, Department of Nephrology and Renal Transplantation, SGPGIMS. To co-chair are Dr. Sukanya Govindan. She is Consultant Pediatric Nephrologist at Mehta Children's Hospital, Chennai, Apollo Children's Hospital, Chennai. Next chairperson, Dr. Vijay Shankar. He is HOD, Department of Nephrology, NMCH, Patna. And another co-chair is Dr. Khushbu Rani. She is Consultant Nephrologist, Narayana Medical College and Hospital, Sasaram. Over to chairpersons to introduce our speaker and other proceedings. Thank you.
Yeah, good morning. First of all, I want to extend my thanks for inviting us. And it's my pleasure to introduce, can I have introductory slide? Dr. Michael Molina, who is going to talk about the changing paradigm of HUS. So it is the time to definitely, it's a very relevant topic, because it is really, there is a changing paradigm, especially in the field of HUS, especially in terms of finding new classification and etiology for the HUS. Dr. Molina is, presently he is working in RVT Great North Children's Hospital, NHS Trust, UK. So without much wasting the time, over to you, Dr. Molina.
Hello, thank you very much for the introduction. I hope the technology works and you can hear me. And I'm terribly sorry that I couldn't be with you in person due to some family circumstances. However, I am very glad that I can have this talk for you. I hope that you can see my next slide that says that HUS is fairly straightforward as it looks like to have the diagnosis. We can have from the description, we just need low platelets, hemolytic anemia, usually high LDH suggesting hemolysis, negative DAT or Coombs test, and high reticulocytes telling us that the bone marrow is working. And together with the kidney injury, together we have the syndrome, which is mostly a description of all the symptoms that we can have. To make it more interesting, it is not that simple. So at this moment, HUS, as we have it, is a part of a very big family of thrombotic microangiopathies. So ranging from the classical bit that we have, and that's on the lower right side, that you have STEC HUS. That was the first etiologically descripted, and then everything that was not STEC HUS, or as it was previously described with the prodrome of diarrhea as a D plus HUS. Everything that came after that was labeled as atypical HUS. So we can have all these that there are around. So with that, we now have a very broad differential diagnosis that we can go under thrombotic microangiopathies, and it is to find which one we can therapeutically approach. So definitely we can go with the infections, and we have now also the options to target some of the primary and secondary TMAs that looks like that there are. Now, more to that, there are overlaps also with the glomerular pathology, like the C3G, as they are sharing some of the etiological background in complement. So with the pathology and the etiology, we know now that the atypical HUS, as we see, the main part is from complement dysregulation. So the first bit, what happens is that the patient is prone either through a genetic change in several genes like factor H, factor B, C3, or MCP, that they are prone to overregulation of complement. Complement gets dysregulated, it deposits on the endothelium gets damaged, and that's predominantly in the kidneys and small arterioles. Actually, we don't know why, which is a very interesting thing, probably due to very specific construction of the endothelium in these vessels. So we have the first phase when it gets dysregulated and endothelium gets damaged. The endothelium then attracts thrombocytes, which sit on the damaged endothelium and also attached to the subendothelial exposed tissue, create microthrombi, and these microthrombi that are then obstructing the organs. We are having an organ dysfunction in terms of kidney, the acute kidney injury, because there couldn't be a good blood flow. And these thrombi are creating a physical barrier that the red blood cells can't pass. And as they are pushed under pressure through this barrier, and they are getting damaged, resulting in what we see on the blood film as schistocytes or red blood cell fragments. The consumption of the thrombocytes can be quite massive, so we have the thrombocytopenia and the target organ damage, in this term, most of the kidney with AKM. Historical management was mostly very much supportive at that time. Firstly, there was not much of an insight what is causing the disease. Some of them were having low complements, some were not having low complements. So the staple of treatment at that time was plasma therapy, plasma exchange or plasma infusions that could have helped in some deficiencies of the complement proteins, or if there are factors that could be eliminated by plasma therapy. It was a very dire disease, and that was mostly all the patients diagnosed had a very high death rate. Usually in the first episode was up to 14%. When we were prognosing these patients and we were telling them what there will be their prognosis, 40% reached end stage in 5 years. There was a slight difference in certain groups based on the genetics, as you see on the table from an earlier review. And there was definitely an experience of relapses, even in the milder one, like the MCP, that the recurrence was even up to 20%, or mostly like every few hours, every few years, the disease could relapse, it could remit, but slowly it reached into chronic kidney disease and end-stage kidney disease. So you see that this disease was seen like a very deadly and also having very high burden of morbidity. And this has changed quite rapidly with an advent of eculizumab, with the seminal papers showing effectiveness of this drug that was purposed originally for PNH and then extended its use because of clever thought that there is a complement dysfunction in these children. It nicely coalesced that the genetics found were also congruent with complement dysregulation, and these patients started treatment, and the treatment was very effective, as you see, prevented really much the end-stage kidney disease, stopped the relapse. At that point, the treatment was deemed that ideally it should be kept for life because the patients are having their genetic risks. So that was the first one, and I'm painfully aware that still, since that this earlier reports, early in 2000, the drug is not available globally, and I come to that slightly later also in my talk. This is the experience of our center, where we, this is cumulative data of the previous cohort in the red line from on the Kaplan-Meier, and in the black line is the treated cohort of our patients after the eculizumab availability. So you see that this is very, in terms of reaching end-stage kidney disease, it is extremely effective. So you have the patients and reaching what was mostly the same numbers as in the review, or if they are on a treatment, they are having normal kidney function, and it is really rare that they would drop their kidney function. So this has put the disease completely on its head and changed it from a deadly and very high morbidity disease with bad prognosis, with an inability to transplant these patients, to a disease that it is not that very difficult to treat, but it had made it from a deadly disease to extremely costly disease. TMAs, we have now covered for several of these, so definitely, and what is in our remit of our center is treating patients with factor-rich antibodies, some unexplained TMAs, some de novo, occasionally for pregnancy, and of course those ones that they are having complement gene mutations. The rest of the diseases is a slightly controversial topic because there are lots of reports of effectiveness in certain types of secondary TMAs, including hypertension and others. However, all the reports are skewed to by, I would say, probably mostly by reporting bias, that when you are having a patient that responds to the treatment, you are putting it into the body of literature. When you are not having that success, you are less convinced to put it, and it creates slightly skewed view in the literature on the more positive side that this works, including the C3G, as it was also in the previous talk. In our experience, even in the early stages and with availability, it is not having much of a stellar outcome, and definitely also in the infection ones or those that are mimicked by sepsis, the treatment is definitely not to be recommended. So with that in mind, we have a treatment, but it is extremely costly. So what shall we do? In England, the decision was made that all the treatment should be passed through an expert center. So that became the advent of the National Renal Complement Therapeutics Center, which provides the diagnostics and also the treatment recommendations for England and recently also for Scotland. So we are having referrals from our colleagues in usually renal centers or on ITUs or PICUs, that they are referring us to patients and asking, could this be a typical HUS, and what shall we do with it? The service is quite highly regarded with this because, as we all know, the disease is fairly rare with a very low amount of patients that they are presenting. So you might be exposed to this disease in about once in a year, twice, or maybe even low. So you are trying to get the best diagnostics for your patients, and you are trying to then get the appropriate treatment. Because when it would be completely liberalize, you would think that in that big amount of patients that they can present with the similar symptoms, like it is, I've shown on the first slide, that you can label as HUS a lot of things. Why Newcastle was picked up as the center for this, there is a track record of quite achievements in research of atypical HUS and complement, where the first mutations were identified in Newcastle in Beck families from the south of England with identification of factor H changes, then progressing into further genes, the CFI, CD46, and also then the involvement of Professor Goodship in advent and initial papers on eculizumab treatment. We are then broadening also the scope for investigating further genes and further involvement of causes and etiologies. And also we are gathering quite large body of data from all the referrals that we can differentiate based on genetics and complement profiles. I will just have a brief overview how our center works. So when we are having a suspected atypical HUS from anywhere in England, there is a referral that we hold a 24/7 service. There is six of us that are involved, definitely not on like a full-time basis. However, most of us are interested in this topic. So we gather over a virtual meeting, usually exchanging messages on a safe platform where we find and decide what is the initial decision, feed it back to the clinician, and drug is administered locally by the referring clinician if it is required. We also provide a courier service, so the samples are couriered to us very quickly so we can do rapid tests for complement, excluding also TTP by measuring ADAMS 13 and for continuing with genetics. What we see also as very important is exclusion of STEC infections, that they are much more common than we thought, and that we can't differentiate definitely on the preceding symptoms like diarrhea. That was thought that it might be quite useful to see from our experience and from the data. It looks like that about 30% of genetically caused HUS are also presenting with some form of diarrhea or loose stool at the beginning. So it is quite useful to have an exclusion, because when you have someone who is having an STEC infection and you would start the treatment, you are not just treating the right thing, you are also quite wasteful in terms of resources, where a very simple PCR rectal swab or stool analysis can identify STEC, and we can exclude this patient from the treatment. This is the rate of referrals. So you'll see a heat map of where we are, mostly covering the large conurbations, but it is quite worldwide referral. They come to go quite rapidly. And since the start of the interim service, and then the service started in 2016, and you see that there is a steady influx of referrals, so you don't need to worry about not having being busy. However, what we try and what we see as interesting is the orange line, that the treated cases are not that much increasing. So people are much more aware of atypical HUS. They are referring it. As you've seen, the diagnosis and the differentials could be quite broad. However, the true genetically caused and the treated cases are quite stable. So you can imagine if this gap would have been lower, then there will, and the amount of eculizumab that could be given might be much higher, which is also in some centers where it is not that, or in some countries where there is either no center or it is less strict with dispensation of the drug. So these are some numbers. These are the latest year. So we have been referred about 230 patients, recommended eculizumab initially in 38. Some of them are referred quite lately. So there was no renal recovery, or there was then later found a different pathology, and as 32 were treated in the year, and you can see that most of them were having some kind of complement mutation or change that, or factor H antibodies that made them prone to develop the disease. So we have now the treatment, and we have now a setup center. So what is next? Next thing that came was ravulizumab. So this is a second generation of eculizumab drug, that it is a C5 blocker on the level of complement in terminal pathway, and eculizumab is given every 2 weeks. And there was an idea: can we make it a little bit better? The company came up with slight changes, engineering small changes in the molecule itself, mostly switching few of the molecules and trying the new drug. There was a study in pediatric patients and also two bigger ones in adults, that all of them shown safety and long-term efficacy of this newly engineered ravulizumab as a second line of treatment. Why it is so interesting? Eculizumab is given every 2 weeks, and you can see how the antibody is recycled, mostly going into the endosome and lysosome, where it is targeted, and then it is taken out of the system. So it is regularly, it needs to have regular redosing. Ravulizumab, due to the small changes, is much more resilient in the body, much more resilient to not get destroyed in the lysosome, and because of the pH changes, it is then taken out and mostly recycled. So it stays in the body for up to 8 weeks, even more. When we have now stopped some patients, it looks like that stays in the body for very long periods, and the dosing is every 2 months. So that looks very good. The label would be, again, that patients should probably stay, that they are appropriate on the treatment for life. And then we are at the end of the road, it looks like. So we have a treatment, patients are fairly happy. There are not that many side effects, fortunately, of this treatment. There is a terrible, yet rare thing that they can have a meningococci infection, because as the complement is blocked, it is possible to have this. However, they are having a vaccine and they are covered with antibiotics for the duration of the treatment. So this chance that it is mostly about 500 times bigger than in the general population can be stopped. So is this the end of it? So we have for atypical HUS the treatment, and that's it. So our current approach looks like this. There is a diagnosis of possible HUS. We stop the treatment when there is an alternative explanation, like I've mentioned, STEC or other renal or hematological disease. We will have the genetic and factor H testing. We will see if some of those that they are not having a genetic change, or they are having a change that it is not responsive to eculizumab, like, for example, children and patients with DGKE, that they are not benefiting from eculizumab treatment, or if there is a futility after 6 months, you will stop. Otherwise, the treatment continues in these patients. Let's get to the elephant in the room, which is that the drug is extremely costly. And as I mentioned, it is not available, as you are painfully aware, worldwide. So is there a role for stopping eculizumab? There were several also attempts to prolong the intervals and do other things, how to rationalize the treatment. But it looks like that the original thought that eculizumab is for life is not the case. So why should we stop eculizumab? First, I have mentioned that there is certain risk that could be quite high in patients. There's about 500 or up to 2,000-fold increase in the risk of meningococcal disease for patients on eculizumab. So it is not without its risks. There was also an opinion of patients that we tell them that there is a limited, if you put it on its head, there is a limited evidence that the continued treatment is required for all patients. So they are asking these questions. There's the burden of treatment. Even now with the ravulizumab, it is much less than you need to have your infusion every 2 months instead of every 2 weeks. But surely, even for small children and other, the treble and all that could be slightly burdensome. Not definitely to the extent, and you need to go 3 times a week for dialysis for life. So this one of the bases, and then there is several rationale for stopping. One of the earliest was in a report from Italy, 10 cases that were successfully stopped without about 30% chance of recurrence of the disease. There is a very good led center in Holland, and in the Dutch experience, they are having a mandatory stop for most of the patients. So they are showing that even when they stop, the rate of recurrence is only in certain genetic traits, and also that it reaches about 30%. And the biggest cohort at this moment is from 2019 from the French experience, from the report from Fadi Fakuri, where they have stopped 38 patients. There were both children and adults, and again the relapse rate was in about 12 patients. Mostly it was factor H variant, some in CD46, and those that they were not having any variant detected, there was no relapse. And that is also in our experience that we see if there is no genetics, it is very unlikely that the patients will relapse. However, even when stopping the treatment, and if there is a relapse, and if it is treated and identified early, there is not much of an late causes of increased risk to the kidney. So it looks like that it might be a possibility that even if the disease is triggered, it can be stopped fairly quickly in the beginning of its presentation as the patient is aware of it and the clinician, and the treatment restarted. We are also running a study in Newcastle in the same topic called SETS, or Stopping Eculizumab Treatment Safely, that I am PI for Newcastle and my colleagues are national leads. We are planning to withdraw 30 patients, and then there is also a smaller health economic arm for patients that they don't want to withdraw, but we are having it as a baseline. The patients after stopping are then followed for 24 months. We are now reaching end of observation period for most of the patients. That should end somewhere in November. And from the preliminary data, it looks like that they are mostly copying the part in France, that it looks like that it is safe to withdraw the treatment. And in certain patients, the relapse will be there, of course, but we were expecting that, and it is about how to make it safe. So the measurements are mostly to the safety of withdrawal and restart of the treatment without causing kidney deterioration or hematological changes or changes in other organs. And we have not seen that. And this is just for an illustration how the change can get into saving into real life, because even from stopping few of these patients, the treatment cost reduction goes to several million. So we are slightly revising our approach. We have a possible diagnosis of atypical HUS, and we can have an alternative explanation where we stop. We will treat with C5 blocking antibody eculizumab. We will do the genetic and stratification, exclude those patients where there is futile or there is a there is the end stage kidney disease because there was probably a later presentation in probably too much advanced disease. And we will see in those that are having a minimal risk, that means that they are having no genetic change, we will likely stop treatment in these patients. And there is low in certain changes like CD46, we might try to stop it too, with an expectancy and very thorough discussion with the patient that there might be a relapse, but if we are vigilant for this, we can treat it again, and we can go into a cycle of not a continuous lifetime treatment, but mostly treating relapses. Then in a large could be fairly less common in most of the patients. Then there are those patients that would have probably a high risk of relapse. That would be factor H mutation, factor H hybrids, or patients that have been transplanted with a kidney transplant and where we don't want to risk even the slightest possibility that the transplant wouldn't be working. So they might be treated further and switched to ravulizumab as a long-term solution for these patients. Considering that there is not a global availability of eculizumab, one needs to work pragmatically. So I have also updated it slightly for how we can approach it with an unavailability. So eculizumab is available, and we can go to my previous label where we have those that we could stop, those that will need to continue. Eculizumab access is limited, so there needs to be default to either a plasma exchange or previous symptomatic care. The good thing is that from large cohort and reports from India that they are excellently covered for factor H antibodies are showing benefit of plasma exchange and treatment with additional immunosuppression to get rid of the antibodies and achieve remission even without the treatment with complement blocking agent. So at least for these patients, there is a chance. So in summary, eculizumab and also its second generation ravulizumab are an effective treatment for atypical HUS. The ideal approach is now to treat early, identify those patients that they benefit from the treatment, stratify based on an etiology, and thus mitigate the chance of long-term damage. Rapid control of disease manifestation that goes with the and re-manifestations. The conclusion is also that eculizumab shown from these 3 reports, and hopefully when we conclude our study, we think that it will show the same level of safety that eculizumab can be withdrawn. And this opens door also for, I would say, a more widespread use of it, because it is very hard to sell to someone. We are having an extremely costly drug, and we will need to treat it in a cumulative way for life. So that creates a tremendous burden. In a term of treating only the active parts of the presentation, it could be much more palatable. It looks like that less than 50%, it looked in the previous ones that they will not relapse at all, particularly those ones that are not carrying mutations. So then afterwards, it changes into close monitoring after withdrawal. And the final approach would be the move towards protocols based on intermittent treatment of acute relapses. With that in mind, it might be even that we are having new drugs that they are targeting complement on certain levels. So there might be even those that will not require infusions, and we'll see what the future will bring. Thank you very much for your attention.
Thank you, Dr. Melina, for that wonderful lecture, and also touching upon how the future of UK HUS service is going to look like. Our experience in India is influenced by the limited access to complement inhibitor therapy. And the largest data comes from the AIMS group. And since Aditi is in the audience, I'd like Aditi to comment briefly on the Indian experience of atypical HUS.
Thank you. Am Am I audible? Yeah. Thank you, Dr. Malina, for that talk. That was excellent, and we really enjoyed it. It was comprehensive, and we always look to Newcastle to bring in new advances in the field of atypical HUS. Thank you for presenting your unit's experience. So in India, Professor Bagga has, with the help of collaboration from French colleagues, helped set up some services for complement diagnostics. Chiefly, we have been fortunate in a way to have had a sizable fraction of Indian children with atypical HUS being diagnosed with anti-factor H antibodies to complement factor H rather than the other abnormalities, and that being the predominant cause for an unknown reason, because the genetic predisposition is fairly similar across the world in terms of CFHR1/3 deletion. That being the cause, we have been fortunate to be able to collate our experience and be able to find that plasma exchanges and immunosuppression works fairly well in this group of patients. So that's been useful for us. We continue to run the test for nationwide samples free of cost, thanks to funding support from various governmental agencies, including the DST, the ICMR, DBT, ongoing funding through projects. But the important bracket of disease remains atypical HUS, which is not mediated by anti-factor H antibodies. And therein, we are beginning to use next-gen sequencing to diagnose these cases and try to manage them well. But obviously, this challenge is because of limited access to eculizumab. We have had the occasion to use eculizumab recently in a few patients, and we can understand why everybody is so awed by this agent and how miraculously the children turn around with therapy. And that being the case, we understand why vascular access and other complications associated with plasma exchanges make it an inferior option for children with atypical HUS, not mediated by antibodies to complement factor H. Having said that, the expense of therapy makes it out of reach for any individual in the country overall because of the cost. We have now initiatives such as the Rare Diseases Initiative, wherein centers of excellence might have access to a limited amount of fund per patient, say up to a ceiling of 50 lakhs for rare diseases. And through that, we are trying to push for access to therapies such as this. But we do need to continue participation in clinical trials such as for crovalimab, avocapan, and other complement and pathway targeting agents so that access to these medications is improved for our country. So thank you, I think.
It was a great insight. I really appreciate, and I really enjoyed all the results that came also from your center on the antibodies. And I'm also baffled by the slight difference in this presentation.
Yeah. Hi, Michael. I'm Rajiv. So
Hello,
thanks.
Rajiv.
So thanks for the talk. Just I wanted to have your experience on MCP. Like we have in our center 3 or 4 MCP positive, and 2 of them are behaving as the textbook says, that like most of them relapse and then goes all right and is well, but the other 2 are behaving very badly, are having very frequent relapse, severe hypertension, a bit of a CKD. And so in your experience, what is your about the MCP, and do you use eculizumab? Obviously we don't have that, but do you have any other suggestions?
So for all patients in England, when they are diagnosed with atypical HUS, and we exclude possibility of secondary type or STEC, we treat them all with eculizumab, including factor H antibodies and CD46. We have with the reports from CD46, we have seen quite a broad range from those ones that they are having several indolent relapses and they are continuing to have quite a good kidney function, to those that you say that they are progressing into CKD after even the first one, and they are difficult to control without any other option. There is a very limited efficacy of plasma exchange, unfortunately, in the CD46, as it is a surface-bound molecule. So they are really quite a candidate of probably the intermittent one treatment, because what we see, if the trigger passes away and we cover that period with eculizumab and then we stop, most likely these patients are safe. However, I have had several now adult patients referred with CD46 that they were in their 40s, around this age, and mostly they said, oh, I was having some kidney problem or hematuria when I was young, 3, 4. Then I was having another one when I was a teenager. They thought that it might be post-streptococcal or something like that. And then it nibbled to on their kidney. And in their 30s, 40s, they were having very progressive CKD, or a few of them also almost at the end stage. And they were also complicated by hypertension. It looks like that when there is this struggle of the kidney for blood and the microthrombi are happening, that they are also presenting with quite high blood pressure.
Thanks. Any other questions? If there is any post-transplant experience of atypical HUS to Dr. Malina?
Quite fortunate thing, again, with the change of the treatment. My first experience with atypical HUS was with a patient that I have met when he was 16. He was after 2 unsuccessful kidney transplants, having a C3 mutation. That was before the eculizumab, and it was horrible. This guy was mostly bound to dialysis, so he was fortunate that he could have had it at night. So he was at home dialysis even before it was more of a thing, because of very dedicated parents, and he was mostly sentenced to this life. After that, there was a found that he was carrying a C3 mutation. This could have been then changed, because he was allowed to have eculizumab before his next transplant, and his transplant was working very well. So we know that patients, when they are covered with eculizumab and going to kidney transplant, the chances of relapse are very minimal. I don't have the slides here, but I could have find it. Most of our patients, where we have now put a report out about transplant experience, so it is also available from our center. Most of the patients are doing really well. The historical cohorts were much more dire, as in even my personal experience. We tend to treat not reactively most of the patients that we know that they are having genetic change. So they are given eculizumab pre-transplant. They are having an extra dose post-transplant covering for reperfusion injury. It's mostly out of caution, and then they usually continue on the complement blocking therapy.
Thank you. In India, we are frequently seeing the pregnancy-associated TMA. Anyhow, TMA is very difficult, whether it is a primary, secondary, malignancy-associated, infectious-associated. It is a very difficult and challenging case for everyone, and we have to be very alert. And the prognosis depend upon the early diagnosis, and the treatment is the comprehensive attitude from the nephrologist, physicians, and pathologist, hematologist, and the treatment is quite costly. So it's a nice discussion, and we are running late, and we conclude this session. Thank you for everyone.
Thank you.
Thank you so much. Thanks to Dr. Michael Molina, because for him it would have been at 6 a.m. in the morning delivering this lecture while we are preparing for the lunch. So special thanks to him.
It was a pleasure, and enjoy the lunch break.
Thank you so much, sir. Thank you. Hello, very good morning. I am Dr. Abhishek. I am a consultant nephrologist at Paras HMRI and the host for today. With this, we have reached the final and the concluding session of this very delightful CME. But this, I suppose, is the most important session for this whole CME. We start this session by a plenary session dedicated to late Professor Dr. I.B. Sinha, sir. The session is Dr. I.B. Sinha oration, Kidney Diseases in Kids and Odyssey. Late Dr. Professor I.B. Sinha is probably the father of nephrology in Bihar. So it's an honor for us to dedicate a session to him. For this, I'd like to call the chairpersons for this session, Dr. D.S. Ray, sir is the senior consultant and the chief of the renal transplant at the Department of Nephrology, R.N. Tagore Institute, Kolkata. Next, I'd like to call Dr. Professor Om Kumar sir. Sir is the professor and head of the Department of Nephrology at IGIMS, Patna. I'll also like to call Dr. N.C. Prasad sir. Sir is a senior consultant nephrologist in Patna and the ex-Director General of Health Services, Government of Bihar. Professor Dr. V.K. Singh sir. Sir is a senior consultant nephrologist and ex-head of the Department of Nephrology at Patna Medical College, Patna. Request the chairpersons to kindly introduce the speaker and carry forward the session. Thank you.
Thank you, Dr. Abhishek. As Dr. Abhishek has mentioned that this is the most important session for this CME. Late Professor I.B. Sinha sir, popularly known as Indu Babu in the community of nephrology all over the country. He was born on 1st of January 1938 in Supor, Jamua village of Munger district in Bihar. He graduated from Patna University in 1960 and then joined the Bihar Health Services in 1961. Then he did his MD in General Medicine and Dermatology from Patna University. He was selected by the government of Bihar for his higher training in nephrology at AIMS New Delhi, CMC Vellore, Jaslok Hospital Mumbai, and then Royal Liverpool Hospital, UK. Then he joined as assistant professor in Patna Medical College, and he retired from that medical college as professor in December 1995. To his credit, he has started the first dialysis center in Bihar and Jharkhand. He was awarded Padma Shri by the President of India in the year 2008. He was conferred Master Teacher Award by Association of Physicians of India, Dronachar Award by the Association of Vascular Access and Interventional Renal Physicians, Lifetime Achievement Award by Tanker Foundation in 2017. He was member of Advisory Committee of Nephrology of the National Board of Examination and member of Board of Appointment for faculty members in various central universities, including Banaras Hindu University. He was editor of Patna Journal of Medicine for several years. He was president of Indian Society of Nephrology in 2002 to 2001, and he was organizing secretary of Indian Society of Nephrology annual conference held in Patna in 1999. So this is the only annual conference of ISN which has held in Patna, and we are still trying to hold the second conference in Patna. He was president of Association of Physicians of India and Bihar branch, and president of Indian Medical Association Bihar branch. For us, it is a very emotional moment, and this is the first CME we are doing without his physical presence. I am thankful to Madam Kumudini Sinha that she is present for this oration function. Please give her a great round of applause. And now I request my co-chairperson, Professor Dr. D.S. Ray, to introduce the speaker for today's oration.
Good morning. I thank both Professor Hemant Kumar and Professor Om Kumar for inviting me to chair a session in the name of Professor I.V. Sinha, who has been a father figure to all of us in Eastern Zone. No conference has been complete without Mrs. and Professor Sinha being there, and it will never be complete also. We'll always feel his absence in the conference. It's good that we are having a stalwart Professor Gulati, who is not only a pediatric nephrologist, he is also an adult nephrologist. He is president of Indian Society of Nephrology, lot of research work and lot of work on transplantations. So we are eager to hear him. Professor Gulati, please.